Today, we're going to break down a really crucial bedside skill, how to accurately and safely measure intra-abdominal pressure. In the ICU, this number can seriously be the difference between catching something early and a life-threatening complication, so getting it right is everything.
So, picture this. You're at the bedside, and you just have that feeling. Something's not right. The patient's abdomen is tense, their vitals are looking a little shaky. You're thinking, could the pressure be high? The big question is, how do you get a reliable number to prove it? Well, let's walk through exactly how to do that.
Here's our game plan. We'll start with why this measurement is so important. Then, we'll get into choosing the right method, gathering your gear, setting up the system, actually doing the measurement, and finally, the super important next steps and reminders to keep your patient safe. It's the whole shebang.
First up, why are we even doing this? Well, measuring intra-abdominal pressure, or IAP, is absolutely essential. It's how we diagnose things like intra-abdominal hypertension and its much scarier big brother, abdominal compartment syndrome, which can be a total disaster if we miss it.
You know, in a perfect world, for a perfectly accurate reading, your patient would be lying flat, totally relaxed, maybe even sedated or paralyzed. But let's be real, the ICU is rarely a perfect world, right? So how do we deal with that?
And that leads to a really crucial point. Because the conditions are almost never ideal, one single measurement might not give you the whole picture. What really matters is the trend. Watching how that pressure changes over time, that's what gives you the real clinical story.
Okay, so we know trending is key. Now, how do we actually get the measurement in the first place? Well, you've basically got two ways to go about it: direct and indirect.
Direct measurement is exactly what it sounds like, sticking a needle right into the abdomen. And as you can probably guess, that comes with some pretty hefty risks, like infection, bleeding, even poking the bowel. So yeah, we don't really do that for routine monitoring. The indirect method, which uses a catheter that's already in the stomach or bladder, is way, way safer. It's the standard way we do it in the ICU.
So what's the gold standard for this indirect measurement? It's using the patient's existing Foley catheter to measure their bladder pressure. See, the bladder acts like this passive little water balloon in the abdomen, and it does a great job of reflecting the pressure of the whole cavity. It's effective, it's safe, and hey, you've probably already got the equipment right there.
So we're going with the bladder pressure method. Awesome. But before we even go near the patient, let's get our ducks in a row. Here is your equipment checklist.
You're going to need that Foley that's already in place, a regular pressure tubing set, and a cable for your monitor. Then go grab a 500 milliliter bag of normal saline, a nice big 50 milliliter syringe, an alcohol wipe, and a clamp, like a Kelly or a chest tube clamp.
And here is a major pro tip that's super easy to forget. Unlike setting up an A-line or CVP, you do not need a pressure bag for this. Nope, we're just using a simple gravity and manual flush system here.
Okay, supplies are gathered. Now for the fun part, the setup. Let's walk through exactly how to put this system together, from the saline bag all the way to the monitor.
First things first, spike your saline bag and prime that pressure tubing like your life depends on it. Get every single air bubble out of every port. Next, go ahead and attach your big syringe to that last stopcock. Then, give the sampling port on the Foley tubing a really good scrub and connect your primed line.
Now for a super critical detail, leveling. If you're used to cardiac monitoring, your brain is probably screaming phlebostatic axis at you. Forget it. For IIP, that's not what we use. The transducer has to be level with the bladder, and your landmark for that is the mid-axillary line right at the iliac crest, basically the top of the hip bone. If you get this wrong, your whole reading will be off.
Okay, the system is all set up, it's connected, and it's leveled. It is now time for the main event, actually getting that pressure reading.
First, make sure your patient is lying flat. Now, draw up exactly 25 milliliters of saline. Next, clamp the Foley tubing after your connection port. You want to make sure that saline goes into the bladder, not the drainage bag. Now, infuse that 25 milliliters, and as soon as it's in, turn the stopcock off to your syringe. That opens up the line straight from the bladder to your transducer.
25 milliliters. Remember that number. It's the standard volume. It's just enough to create a nice fluid column for the transducer to read, but not so much that it starts stretching the bladder wall, which would give you a falsely high pressure.
And now for our second key number, 60 seconds. After you push that saline in, you have to wait a full minute. Why? This lets the bladder muscles, the detrusor muscles, just relax. If you measure too soon, you'll get a high reading from that muscle contracting. So be patient.
Once your minute is up, look at the waveform on the monitor. You'll see it go up and down as the patient breathes. To get the most accurate reading, you want to grab that pressure right at the very end of expiration, when the waveform is at its lowest. This gets rid of any extra pressure from their breathing.
Okay, you did it. You've got your number, you've documented it, but you are not done yet. There are a couple of absolutely critical cleanup steps we have to talk about.
We've now arrived at the single most important safety check in this whole procedure. Whatever you do, do not, I repeat, do not forget this next step.
You must unclamp the Foley drainage tubing. Seriously. Forgetting this means the bladder can't drain. That leads to urinary retention, and that can lead to acute kidney injury. It is easily the most common and the most dangerous mistake people make with this procedure.
Let's just run through that post-measurement checklist one more time. First, unclamp the Foley. Second, remember to subtract the 25 milliliters you put in from the patient's total urine output for that hour. If the pressure was normal, great, you can take it all down. But if it was high, say over 12, you're going to want to leave that system in place. It makes it so much easier to get quick repeat measurements for your trend.
And that brings us right to the final critical question. You've done the procedure perfectly, you've got a high number, and you know the clock is ticking. Now what? Well, that's where measurement ends and intervention begins.